Good morning. At the outset, I'd like to thank Dr. JB and the organizers for giving me the opportunity to take part in this lovely session. I'll be speaking on viral anterior uveitis. Now, the most common viruses involved in anterior uveitis are from the herpes group, and more recently, rubella has also been implicated. Now, herpes simplex virus and varicella zoster virus related uveitis is the most common type, and it's often difficult to distinguish between these two in many cases. In general, simplex viruses tend to occur in younger patients and zoster in older individuals over the age of 60. Of course, if you have the skin lesions and the classic presentation of herpes zoster ophthalmicus, the diagnosis is easier to make. Also, for zoster related uveitis, older age and immunosuppression are risk factors. Now, the presentation in most patients is an acute episode of raised intraocular pressure with few inflammatory signs. And always remember, in the presence of open angles, we cannot confuse this with angle closure related issues. When you see the eye, in most of the patients, the eye looks quiet. There's very little signs of circumcorneal congestion or corneal lesions or even keratic precipitates. But I cannot show you patients of pictures of normal looking eyes, so a lot of my pictures will show corneal lesions, but that is not the case most of the time. And eventually, with recurrent attacks, you may get signs of synechiae and more obvious corneal lesions. Very often you'll have to look, during the acute episode, you'll have to look at the angle, not only, of course, to rule out angle closure. You may find keratic precipitates located in the angle, because finally, ultimately, this is a form of trabeculitis, and that's why we do not see so much inflammatory signs in the anterior chamber. The keratic precipitates range from small, medium to large, and they're often not in a Arles triangle distribution. They are often located just behind the zone of the corneal endothelium, which is involved. You may not see actual endothelial opacities, but the KPs are often located behind involved areas of the cornea. Descemet's folds often seen when you have the acute episodes in viral endothelitis. Of course, the skin lesions of zoster ophthalmicus provides a clue to the etiology, and sector atrophy of the iris. This again is a strong sign pointing towards viral anterior uveitis. In some patients, you may just have sphincter atrophy. So if you see an eye which is dilated in the absence of pharmacological agents, again that might suggest viral etiology. Hyphema has also been reported in herpetic anterior uveitis. So now we'll move on to other types of viral anterior uveitis. We know that glaucomatocyclitic crisis, Posner-Schlossman syndrome, all of these terms are essentially used to describe patients with acute rise of intraocular pressure, unilateral, in the presence of open angles, and a few inflammatory signs. Recently, there are reports that cytomegalovirus is implicated in over 50% of cases with this presentation. You must have seen a slew of articles reporting the association of cytomegalovirus with anterior uveitis. Going over about 15 odd articles, the most common clinical features of cytomegalovirus associated anterior uveitis is recurrent anterior uveitis and ocular hypertension, endothelitis, and chronic anterior uveitis. Fuch's heterochromic iritis was considered idiopathic till recently, when reporters from the Netherlands started isolating rubella antibodies. In some series, almost 100% of cases with Fuchs heterochromic cyclitis. And subsequently, other authors have also confirmed the association between rubella and Fuchs heterochromic iritis. And in case you want further proof, the Birnbaum et al. Have done an epidemiologic relationship between Fuchs heterochromic iritis and the United States rubella vaccination program. And they've seen that in every subsequent decade after 1959, after the program was introduced, there has been substantial reduction. You can see a 64.8 reduction in Fuchs as compared to patients with idiopathic granulomatous uveitis. And with every decade, the incidence of Fuchs has been coming down, while it has not changed significantly for idiopathic granulomatous uveitis. And the percentage of foreign-born patients with Fuchs increased relatively in their series. Now we move on to the complications of viral anterior uveitis. The most significant complication is actually glaucoma. Due to the repeated attacks, the damage to the trabecular meshwork, I think the problem is largely seen in the glaucoma OPDs and not so much in the uvea OPDs. So many of them will require multiple medications, surgery very often. Addition, and of course recurrent attacks causing corneal opacification. It's not surprising to have corneal opacification because ultimately there is an element of endotheliitis. So you do have endothelial cell loss over a period of time and loss of clarity of the cornea. Now, cataract is inevitable considering the number of times the attacks occur and the use of topical steroids in many of these patients. Now, the investigations are often really, we do talk about aqueous tap and the PCR, but the diagnosis is often clinical in most of the cases. Anybody coming in with a unilateral cause of acute rise in IOP is presumed viral. Of course, if there are atypical features, an aqueous tap can easily confirm the diagnosis. I will not be going over the treatment because Suchitra is covering the treatment. And of course, most of our treatment involves topical and antiviral agents. Acyclovir eye ointment is used only in the case of epithelial disease. And of course, the toxicity is there. We need to restrict the use once the epithelium is healed. Now, recurrences are frequent. Very often the patient is symptomatic, they come back to you with, they know when the recurrences occur because the pressure goes up tremendously, they have this heavy feeling in the eye. There may be more obvious signs, but sometimes the signs are very subtle. There may just be a small crop of fresh keratic precipitates, a new lesion of corneal vascularization. And recurrences are also often treated the way we treat the original episode. Now, we're wondering about the use of long-term acyclovir. We do not have information for just purely viral anterior uveitis, but the herpetic eye disease study recommended long-term acyclovir to reduce recurrences in herpes simplex virus-related stromal keratitis. In cytomegalovirus, despite the use of long-term ganciclovir, in many cases up to 8 months to 1 year, while the patients did well while on ganciclovir, they recurred in almost all cases within 8 months of stopping the ganciclovir. So again, guidelines for long-term treatment are at present not really there because so we end up just treating recurrences with the antivirals. And it also makes sense to have limited antiviral cover at the time of planned cataract surgery. We need to time cataract surgery, of course, when the disease is inactive. And depending on the number of corneal lesions, synechiae, how much manipulation we're likely to use, we will need some oral antiviral cover around the time of cataract surgery because we are going to use intensive topical steroids in the post-operative period and we do not want a reactivation of the disease. Of course, in immunocompromised patients also. But even in immunocompromised patients, long-term acyclovir has not been shown to reduce recurrences, by the way. Resistance is actually fairly rare in immunocompetent individuals, more of an issue in immunocompromised patients. And unlike other forms of uveitis, actually this is one place where vaccination probably has a role. Just like we saw the reduction in Fuch after the introduction of the rubella vaccination program. At some point in time, if we have a little more effective virus, the problem is the vaccines against varicella zoster are not terribly effective. They have limited protection for about 10 to 15 years. So people are considering making it biphasic, introduce a vaccine for older individuals, also to reduce the morbidity due to zoster in older patients. And then that might in future years, we may see a change in the epidemiology of viral anterior uveitis if vaccination becomes more prevalent. 1 minute, sorry. Yeah. So in conclusion, viruses are a well-known and important cause of anterior uveitis, especially those with raised intraocular pressures. And the mainstay of treatment is antivirals, topical steroids, and IOP control. We have limitations with long-term use of antivirals in this case. And however, early treatment, especially with primary attacks, may prevent recurrences and complications in this condition. So, thank you.